Good morning, everybody. My name is Richard Parrish. I have the privilege of chairing this webinar today. This is a joint initiative between the NHS Confederation and the National Centre for Rural Health and Care. We've had a very strong relationship with them at the National Centre, really since we were formed about 3.5 years ago. That is developing into an even longer term strategic partnership. We have other partners as well. The Nuffield Foundation, who will be represented here today by Billy Palmer, who is speaking, and the Rural Services Network, which looks after rural local authorities. And between us, we also contribute significantly to the National Rural Coalition. So we're very much focused on rural communities, coastal communities, and those in remote areas as well. Today's webinar is very much focused on the impact of COVID on rural coastal communities and the opportunities for all of us to influence the agenda for the future. We will be launching a community of interest to support the membership of our organizations and looking at how we might influence that future agenda. I'm going to ask you if you would please keep on mute unless you have a question to ask later on in the session. Just by way of introduction, I think it's fair to say that COVID has been the health challenge of the century. It's had an impact not just on our health and on the services that we all deliver. It's clearly had an impact on the economy, on our family and social life, on the environment, sometimes for positive reasons as well. And it has tested our resilience and the resilience of people, our communities, and our systems. I think the sad thing from my point of view, having been part of a loose United Nations group looking at future challenges, this was both predictable and indeed was predicted as far back as the late 1980s. But it has had a differential impact on rural, coastal, and remote communities. The challenges we've had to face have been rather different from some of the urban communities. The impact on our health and social care services, on the non-health care services as well, those wider community services, on access to some of the basic requirements for living. It's tested our digital connectivity to the limits in some parts of the rural part of the country, and it's also exposed the under-resourcing of our rural and coastal services. So today we're going to look very much on the impact that COVID has had, on the implications for the design and delivery of services for the future, how we can influence the place agenda, both as individual organizations and collectively, and how we can engage all of you in a future ongoing conversation so that collectively we're more influential than we would be just as individuals. So that's my introduction. We've got a panel of people. We're going to start with Dr. Kieran Sharrock from Lincolnshire. I'm going to ask each of the speakers to speak for 5 minutes, including a very brief introduction just to explain who they are at the start of their session, and then we'll move through the other speakers. So Kieran, if we could start with you, please, from what I believe is sunny Lincolnshire today.
Yes, thank you very much. Yes, it is sunny here today. My name is Dr. Kieran Sharrock. I'm a general practitioner in Lincolnshire, and I'm also the medical director of Lincolnshire Local Medical Committee, which is the representative body for general practice across Lincolnshire. What I've been asked to do is briefly give an outline of how coronavirus has affected general practice in Lincolnshire. So I assume this is going to be a very similar picture across other parts of the country. And the thing with Lincolnshire is it is a very rural county. It's the second largest geographical area, but with a fairly small population of only 750,000 people. So they're spread out over a very rural area. There's also a large coastal community along the east coast around Skegness, Mablethorpe, and that part of the county, which has high levels of deprivation. So I think this is a picture you will see across lots of other rural and coastal communities. So what I can give you is a brief description of how general practice has been affected by coronavirus, and then explain how being rural and coastal has made that worse in some respects. So general practice throughout this pandemic has had to cope with a change in the workload and the way we work. What's happened is that at the start of the pandemic, we were advised that we shouldn't have patients in our surgeries, so we were closing the front doors and keeping people out and moving to something called total triage. So whereas before patients could walk into our surgeries, make an appointment in a week or two, we were then told that no, they shouldn't be able to walk in. Everything should be done remotely by either internet or telephone, and that we should then not book patient appointments face to face unless it was really clinically necessary. So at the height of the pandemic, probably 5 to 10% of patients were being seen face to face, and the rest of our contacts were being dealt with remotely. That meant that at the very beginning of the pandemic, for the first maybe 2 or 3 months, the workload in general practice dropped off significantly. So whilst the pandemic was building in hospitals and acute trusts, general practice actually went quite quiet, and it gave us a bit of a respite from the previously very busy workload. We weren't doing nothing, but we were still quite quiet, and it meant that we were back to how it felt like in the 1990s with the sort of levels of workload we were having. But as soon as the first wave dissipated, patients started to return in their numbers. And actually throughout the pandemic, since the first sort of 3 to 4 months, the numbers of contacts that general practice across the country has been seeing has increased significantly. And this is probably based around 4 or 5 different factors. One is that during that 3-month hiatus, people's conditions were getting worse and they were frightened of coming to be seen by their GP. And so they're now presenting with significantly worse long-term conditions than they had before. So whereas before we were managing people's long-term conditions and keeping them static, that 3 to 4 month hiatus meant that their conditions have got worse. The other thing is that people who would have presented during those 3 or 4 months presented much later. So we're seeing people who unfortunately have worse cancers or new diagnoses that are being diagnosed a little bit too late. The other thing is that having a general health pandemic has meant that people are much more concerned about all their minor illnesses. So we're seeing significantly higher presentations of just minor illness than we were pre-pandemic. And then the thing that's taking up probably 50% of our time now is mental health concerns. So the pandemic, as we know, has had significant impact on people's mental well-being. And so whereas before probably a quarter of the contacts I had and my colleagues were having were around mental health issues, now probably 50% of them are. So those things have created a tsunami of workload in general practice. And we are still trying to do this with social distancing, with cleaning down our surgeries between patients, and with trying to do these sort of things remotely where possible to stop the spread of the virus. Now that's the same in every general practice across the country. So why has this been a problem, particularly in a rural and coastal area? Well, what it's done is it's exacerbated the things that were a problem before the pandemic. So rural and coastal areas have always been traditionally difficult to recruit health professionals to, and social care professionals. So when you have a sudden tidal wave of workload, the already diminished workforce finds it much more difficult to cope. And actually, we have a much older generation of general practitioners, health nurses and social care workers working in rural and coastal areas. And they are much closer to that point where they can retire. And actually, we've seen a significant number of them retire early as a result of the stresses of the pandemic. And people are telling me on a daily basis that as soon as the pandemic has passed, that they're going to go early because they feel that they can't cope with the pressures that it's created. So that's one of the things that's had a significant impact here. The other thing is I think that it's also worsened the already present inequalities with deprivation. We know that rural and coastal areas have a hidden level of deprivation that people don't see. Access to the internet, access to good telephony means that this sort of remote consulting with both general practice and hospital trusts has been more difficult for our populations. And I think that's made their health inequalities worse. There's also sort of the other things around schooling. And I know that's not strictly health, but a lot of health promotion happens in school. And there's a lot of safeguarding issues which are dealt with in school. Children are present in school with a health concern, and whereas a parent may not encourage the child to present to a doctor or nurse, the school may do that. Whereas whilst the pandemic was happening, children weren't going into school. So we're seeing a lot of children with physical illness that we probably wouldn't have done before. And I think that's worse in a rural community because the distances between the school and home are greater, and therefore people were less likely to travel into school when they could during the pandemic. There was we've seen significant impact from that. So that's just a brief summary. I mean, I could talk about other things like the hospitals moving to remote consulting having a big impact on general practice and people's health, because if the hospital is remote consulting, that's great. You don't have to travel to the hospital. But then if you need tests and investigations, where do you get them? And in a city, that's fine. You can just go into the hospital and have it done. But in the rural community, there's in our local community, we have 3 major hospitals in 3 towns, but only one of them is doing the investigations now, and that's further away from the majority of the population, because we're trying to keep COVID negative patients in only one hospital. And so that one hospital is doing all of the sort of the investigations and elective surgery. So there's those sort of things have impacted, and that's the same thing across the country, and that has a big impact on general practice. Remote monitoring I could talk about as well, and it's more difficult to do remote monitoring in a rural and coastal setting. But anyway, so that's how general practice has been impacted, and unfortunately, I think that the pandemic has made a widening of the gap in the health inequalities for our populations.
That's great, Kieran. Thank you ever so much for getting us off to such a fantastic start. I suspect that the issues you've raised at the end there will come through as some of the questions when we collectively take the questions. I would also be interested, although not for you to answer now, but maybe a little later, what impact you think this has, that the COVID has had, and the new ways of working, on how you make perhaps better use of the primary care workforce and look at maybe a redistribution of roles and responsibilities. But that's perhaps for slightly later. So I'm going to turn now to James Devine, Programme Director for the NHS Confederation, also with a background in acute care and delivery as well. So I think there's a nice juxtaposition here between what Kieran has had to say and what I think you're going to be saying to us as well, James. So over to you, please.
Thanks, Richard, and good morning, everyone. My name is James Devine. I'm the director of the acute care network at NHS Confederation, and as Richard said, I was between 2018 and the beginning of 2021, I was the chief executive of a trust in Kent, which has many rural and coastal parts to it. But today I want to just talk to you for a few minutes, just taking us through some of which Kieran has very clearly articulated, and some of the challenges that we see from across the country when speaking to our members over the last few weeks and months on better understanding the impact of COVID, particularly, as we say, in rural and coastal communities. But I think to state the obvious, I think firstly, we know that rural and coastal communities are where many elderly parts of our population reside, and COVID has most certainly disproportionately affected the elderly population and those living in rural and coastal communities. when it comes to sadly mortality. And in doing even analysis during my time as a chief executive, it was very clear in parts of particular postcodes of catchment areas of hospitals, particularly in coastal areas where there was more deprivation, mortality sadly was higher than in more affluent parts of the catchment area. And that may well be no surprise. That's been well publicised over the last year or so. But Kieran touched on the impact that's had and the health inequalities that it has both exacerbated but also exposed. And I think it's really clear that we don't just simply treat health inequalities as the latest buzzword for the NHS. It has to actually mean something about how we are genuinely going to address the health inequalities and how we look to work as an integrated care system to address some of those issues. And I know Nicola and the team at the Isle of Wight have done some fantastic work about how they've worked together to address some of the concerns on the island, which I know she'll talk about today. We also know that even pre-pandemic, the workforce issues that Kieran touched on were worse in rural and coastal communities, both in terms of availability of that workforce, cost of that workforce, but also age of that workforce. And it's very difficult then for rural and coastal communities to then attract a younger workforce into those areas. And I'll come back to that and the impact from COVID in a moment. But there's also the issue around the accessibility of healthcare, both before, during, and now as we come to the end of this particular perhaps phase of the pandemic. And we know that the impact from the first wave of COVID to now has seen a significant exposing of issues relating to rural and coastal communities, particularly when it comes to things like cancer care and emergency admission. So we know that cancer care first consultant appointments have significantly dropped by 2/3 compared to pre-pandemic when we compare to urban areas. And we also know from members that emergency admissions fell significantly during the pandemic, more so in rural areas than in urban areas. And Richard touched on the impact that we're now seeing, particularly in primary care, but spilling out now in most recent weeks into emergency care. And that's not to say that people can't get appointments necessarily, although that's true in some part. What we are also seeing is a belief that people don't believe they will be able to get an appointment in primary care because they see that it's busy, and therefore that spills over into emergency care, so emergency departments within acute hospitals. And what our members are telling us from an emergency perspective is that they now have become overburdened to the point that what they're seeing now in early July is what they may ordinarily have seen in a pre-pandemic winter. So this is a really significant issue, not just for the component parts of healthcare, but for healthcare more generally. We've also seen, as again Kieran touched on, that impact in rural and coastal communities in terms of long-term care provision and of course mental health provision. And what that's meant is that people are now coming forward with either exacerbated conditions because they haven't been well managed through no fault of any individual or organisation, but to the point now where those conditions either require hospitalisation or more intervention than they perhaps would have done had patients come forward as they would have done pre-pandemic. And if we put that in context, what that means is what we're seeing now in the acute setting is a 113% increase in mental health patients, so children and young people with eating disorders. And we're also seeing in parts of the country a 50% increase in paediatric patients presenting to the ED, and mostly with conditions that perhaps ordinarily would have been treated with over-the-counter medication, for example. So we are seeing a level of anxiety, I think, also appearing within communities, and that's worse in areas where there is less accessibility to healthcare, so in rural and coastal communities. But if we touch on the broader impact of COVID on rural and coastal communities for a moment, and we think about the economical impact, and again, Kieran touched on the workforce, the cost is much higher in rural and coastal communities because you're having to attract more people into those areas that perhaps wouldn't ordinarily work there. And if we're wanting to attract a younger workforce for the reasons that Kieran stated in terms of retirements and age profile within rural and coastal communities, there has to be something within those communities that a younger generation will want to see in those areas. And if we put the context that during the pandemic, 1 in 5 pubs in rural communities closed permanently, many local amenities closed permanently during the pandemic because they couldn't cope despite some funding support from government. And that's huge for local communities as we come out of the pandemic, whether we agree or disagree that we're doing that. But as we venture out of restrictions, we find ourselves in a position where rural and coastal communities will want to socialise again. And of course, for some coastal areas and rural areas, those areas where they would have socialised as communities are no longer there. And that has a detrimental impact on health. That also has a detrimental impact on the economy in terms of regeneration, which of course is a long-standing issue in terms of investment for rural and coastal communities. And then finally, we then move into the here and now, and we look into the next 6 months and what our members tell us in terms of that link between primary care, acute care, and rural and coastal communities in terms of age profile, particularly, is the vaccine booster. And Kieran touched on how busy the primary care services are, and that's absolutely true. And we hear that from our primary care network colleagues. And we also see that level of anxiety increase, knowing that the services who are going to be asked to administer the vaccine booster in the winter period will be hardest hit in those areas that have over 50s. And of course, that is primarily in rural and coastal communities. So there is a real sort of growing challenge that we see today across health and care from the impact of COVID. But not to sort of quite be the doom and gloom, but I don't think it's over yet in terms of understanding the impact, both in terms of health, so cancer care, emergency admissions, long-standing care, the economical impact in terms of those amenities that people would have enjoyed to improve health. They're not necessarily going to be there in the same way. And then we come on to this ongoing real resilience issue of the NHS workforce, particularly in those areas like rural and coastal, where the vaccine rollout perhaps will have a bigger impact because of the age profile in those areas. So the impact of COVID is we talk about long COVID in terms of a medical position, but a long COVID in terms of recovery for health inequalities. Finally, we heard Matt Hancock when he was at the NHS Confederation conference. We'll ignore other issues relating to him for a moment, but we'll focus on what he said at the conference, and that is the only solution to genuinely dealing with health inequalities is collaboration, collaboration, collaboration. And I think it would be great to hear from the work, as I said earlier, that the Isle of Wight have done in really genuinely collaborating to improve health and care for the residents in their area.
Okay, that's great, James. Thank you very much. And thanks for providing the continuity link to our next speaker as well. When we come back to the questions in a little while, you might be wanting to think about how the emergence of integrated care systems might be used to best advantage, particularly in rural and coastal areas. But we'll deal with that in a little while. You mentioned Nicola on the Isle of Wight. Hello, Nicola. We'll be bringing you into play in just a moment or two. I know that Nicola is a migrant from the wild moorlands of Derbyshire to the sunny beaches of the Isle of Wight, but that's perhaps for another day. Nicola, would you be kind enough just to briefly introduce yourself and to give us your 5-minute starter for 10, please?
Of course. Can you hear me okay, Richard?
I can. I can't see you, but I can hear you. I can now see you as well,
okay,
with a picture of the needles in the background. So
I
yes.
have, yes. Morning, everyone. Thank you for inviting us today. So my name's Nicola Longson. I'm the Director of Operations for the Community Services as part of the Isle of Wight NHS Trust. I'll talk to you a little bit about the Isle of Wight first to just set the context, talk to you about our experience and what happened through the COVID period, and then go on to summarise some of the things we did across the island to enable us as a community provider to be able to respond to the pressure of COVID. So the Isle of Wight, 23 miles wide. You're seeing the West Coast Needles there in the picture in the background. It's 13 miles long, 23 miles wide, accessed by sea and air only. So we do have weather dependency issues, particularly challenged often by fog throughout the whole year. We have a population of 142,000, and again, like Kieran described, high levels of deprivation across the island in pockets. We have 2.5 million visitors roughly annually, and we have a really large music festival that happens once a year. So my experience in Derbyshire of increased pressure over the winter, you see it at both ends of the year. Here we have increased pressure in the summer due to visitors and holidaymakers and the festival, and then the winter pressures due to our older population, which brings me into our population makeup. We have an old population on the Isle of Wight. We also have a population where people are often very socially isolated, which does make it quite unique in terms of not having that social and family network around them. On the plus side, though, we have a very large voluntary sector contribution. We have about 1,500 voluntary sector organisations on this tiny island, which is a real benefit in terms of being able to work with the voluntary sector in partnership. We're a single system, so we have a single tier local authority, single integrated NHS trust that provides acute, ambulance, community and mental health, and a single CCG that's just partnered with a bigger CCG on the mainland. We experience workforce challenges in the same way as others do, but are often really challenged because our workforce is quite contained on the island due to the cost of travel to get over that really small patch of water between us and Portsmouth and Southampton. In terms of the community division, we provide a real broad range of community services from community nursing through to specialist orthotics and prosthetics. And on the island have also been required to provide, for example, the swabbing site as part of the COVID response. Setting things up on the island is quite difficult with a separate population and defined workforce. We work in conjunction with primary care where we can around our 3 localities, and roughly the PCN localities are around 42,000 population, which is really quite positive and a good starting point. So on to COVID. In December last year, we were doing December this year, or last year, 2020, we were doing really well. We were one of the only tier 1 areas across the country. I think there was 3 of us at that point. Unfortunately, what that resulted in is lots more visitors to come to the island on the ferries and enjoy the run up to Christmas, which resulted in us really quickly moving into tier 4 in December, more or less instantly switched from tier 1 to tier 4. The hospital started to get challenged really late on in December, and worse still, we started to see real challenges around staff sickness. I remember coming into work one day early in January and there being 25% of staff off sick that morning, just in my division alone. And I think it's safe to say we are, I'd call it small and beautifully formed, which is probably what most of your other organisations that work in rural areas have to be structured like. We have a range of services and a diseconomy of scale, so we have to try and cluster our services together to ensure we've got the capacity and resilience to meet patients' needs. So what did we do? I remember the very dark morning on early January. I think in terms of how we responded to COVID, we did it very much in partnership. So we recognise on the island that our partnerships make us stronger. It is certainly easier with a one-to-one relationship with many of our partners, one unitary authority, one each of the divisions in an integrated trust and one CCG. So that enables us to come together. We also have a really strong voluntary sector, as I've just talked about. So we work really closely across our partnerships to try and wrap care around the patient. In terms of acute and community partnership, we work really closely with adult social care across the whole pressure period of COVID. We saw things like regular meetings being put in place between the senior system leaders for the different parts of the system. And what that enabled us to do is share ownership of the risks and issues that we faced on a daily basis. Nothing was ever the acute's problem or the community's problem. It was our problem as a system. And the relationships that we've worked on for the last at least 5 years have really enabled that to be quite solid through the COVID period. We also work really hard to continue to engage our partners. So, for example, the voluntary sector are part of our integrated discharge team. The integrated discharge team is an umbrella service that works across acute mental health community and the voluntary sector, based in the hospital, supporting discharge and getting people home safely. And we've got a really developing good relationship with our care homes and independent sector through the links with the local authorities. So really tried to move trusted assessment to be in a seamless journey, which really helped. The other things that we did in terms of the response to COVID, one would have been the use of business continuity plans. As I talked about, the workforce challenges we faced meant we had to manage our staff, our demand and capacity on a day-to-day basis within the division. We upskilled staff really early on in the crisis. We were monitoring demand on a daily basis, and we were having to move staff out of non-life critical services into life critical services to essentially keep the show on the road over that COVID period. We also made the best use we possibly could of technology enabled care. So really early on in the crisis, we implemented our 2-year plan for putting remote monitoring into care homes across all the care homes on the island. So every care home on the island had devices, training and video consultation capability, and it meant we could still access those settings even without having to physically go in throughout the crisis and support the homes. We put speech and language therapists were on tele-swallowing, which meant they could do the dysphagia assessments remotely, for example, and again continuing that through the pandemic without needing access. We implemented, another example would be video consultation across 120 services, 1,000 registered users, and we did 8,900 video consultations that period. And also we put technology enabled care into our care home and at home COVID service and our long COVID service. So tons of things going on, and we've also still trying to work out now how we identify what the long-term pressure is in terms of modelling the suppressed demand and the impact that it's having on our population going forwards. I hope that's enough of a whistle-stop tour, Richard.
Whistle stop it was, but a great summary, and I think you might want to be thinking a little bit when we come to taking the questions about the implications and the learning that perhaps the new integrated care systems can take from your integrated system on the island. But for the moment, we're going to move on to Catherineissen in Cornwall. And Catherine, I think you're going to bring a slightly different perspective. And after that, just perhaps I'll ask you to say a little bit about some of the broader social and economic effects as well. So Catherine, perhaps you'd like to just introduce yourself, please.
Okay, thank you, Richard. Good morning, everyone. I have got a slightly different take, and Nicola did a really good job on giving me a bit of a segue by talking about the voluntary sector. So my name is Catherineissen, and I'm the Chief Executive of Cornwall Rural Community Charity. We are one of 38 rural community charities in England, and we work together in terms of improving quality of life for people working and living in rural areas. As some of you will probably know, we are the most coastal county of the UK, and with that comes lots of different problems and challenges that we face. It's been really interesting in this past year to see the difficulties we faced, and I know, like many other people today, we've talked about how the challenges have been exacerbated by the pandemic, although looking at what we were already facing. Cornwall's got two very distinct sides to it. You've got the coastline, which is quite affluent and very expensive. We've got a very increased ageing population. We've got about a third of our population is over 65. And then you go slightly inland and you'll see some of the highest deprivation in the country. particularly two towns, we've got Camborne and Penzance, are in the 10% most deprived areas of the country. And if any of you saw the Simon Reeve programme on Cornwall that he did last year, it was really quite amazing to see a different side of Cornwall being portrayed, and that's the Cornwall that we see on a daily basis. So our rural community charity is quite complex. We run lots of different projects, and we work greatly in partnership with both the local authority and the NHS and our voluntary sector as a whole. Just a bit of a background on CRCC. Some of the projects we run, particularly big ones for us, are the Cornwall Carers Service. So we work with unpaid informal carers, of which there are about 63,000 in Cornwall. And we are providing support, signposting, access to carers assessments for people who found themselves to be an unpaid informal carer. And that has really been exacerbated by the pandemic, when people have had to live at home and care for family members or friends, for example. So we've seen some real difficulties from that. Health-wise, I think we've seen the increase in mental health issues that I know Kieran was talking about earlier on, both for the carers and the cared for. We've got real concerns about isolation. We've got real concerns about people getting out and about, and also whether or not they want to. You know, it's really interesting. We have a staff of about 100 people at any one time, and we've kept in contact throughout the year. And a lot of us who live in Cornwall don't go out during the day, because we have so many visitors to Cornwall, particularly in the summer, that you can't get anywhere, you can't go anywhere. And there were stories last year of people on holiday refusing to wear masks or social distancing because they've come here to get away from all of that. So a little bit similarly to the previous speaker, Nicola, you know, we were quite safe and not doing too badly in terms of where we were in COVID. And then we've had half term and G7, and the cases in Cornwall have actually absolutely skyrocketed in the last couple of weeks. So I think we're seeing the impact of COVID more now than perhaps earlier on. We also run lots of other projects. We do a lot of IT support. So we've helped people during the pandemic get online and be able to access things like online banking, how to do their shopping online, how to order prescriptions, and also how to FaceTime and speak to their friends, their families, that kind of thing. So it's been brilliant on the one hand that we've been able to increase that communication and reduce some isolation. But as Richard mentioned earlier on, the digital divide is really problematic. The lack of broadband is really problematic in Cornwall. If any of you have been here on holiday, you may have noticed. It's really a challenge for us. So a lot of the problems that were already there, we're still seeing. We also only have one hospital in Cornwall. We have Trellisk Hospital, where the waiting lists were already over a year. There's really huge difficulty in accessing a lot of those services, transportation in Cornwall, as well as being able to get those appointments and the waiting lists. And when we're faced with our ageing population, you can understand how that's been exacerbated. I think really what we've seen over the last kind of 18 months has been quite spectacular. I was new into my role about 18 months ago, and wondered what on earth I'd walked into, really. And it's, you know, we went from so many daily meetings, that I'm sure many of you did, to those now reducing, but a much improved and increased collegiate approach to things. What's been amazing across the voluntary sector is how everyone's come together to work together. And hopefully you've seen this in some of your other communities. You know, we are one of the largest charities in Cornwall. We support lots of smaller charities in Cornwall, and we've seen a decrease in smaller charities, but an increase in mutual aid groups and local community groups that have sprung up, who've really wanted some support. So we've been able to offer support in terms of safeguarding, in terms of governance, in terms of accessing people. And what we've found has been the best approach is to kind of take some of that challenge out of the equation, that competitiveness that was there for many charities. So 18 months ago, we set up the Voluntary Emergency Resilience Alliance, and we were having daily meetings. And what we were able to do as chief execs was to come to the meeting and talk about any particular challenges that we knew of that we needed to escalate it, or we needed help across the sector to work together to see how we were going to respond and help individuals and groups in need. And that's been really interesting. It's been very interesting to see how different chief execs have worked together, how we've learned about each other's organisations, and what it's meant is a reduction in that competition, and it has meant much more collaboration and working together. So, for example, with the Cornwall Carers Service, which came to an end in July, we are now the lead partner, but we're working with other partners like Age UK, Disability Cornwall, and some smaller charities, which means that the people that we're working with in the community get the absolute best that they possibly could. So I'm really proud of our team, and I'm really proud that we're able to work in that way. I think what also has sprung up is that, you know, with voluntary sector, we are able to tender for lots of contracts, be they NHS or Cornwall Council, but a lot of the time we are also seeing need in the local community because of the work that our team are doing. So what we've been able to do at CRCC is look at what that need is and respond to it. So we're doing lots of action research projects on a small basis, seeing how we get on with them, and then looking at if we can kind of duplicate that and how we grow those projects to meet the need of our local communities. Because actually, I think what we're seeing on the ground is, you know, some huge deprivation. We're seeing, particularly in the Camborne area and the Penzance area, that debt is extreme. I know everyone's talked today about health issues and how people haven't come forward with their health issues, which we've seen, absolutely. Mental health issues we've seen, but actually what we're seeing that's really frightening to us is the levels of poverty and deprivation, and the debt that people have just buried their heads in. Kind of leading on from that, when Richard was talking about the social and economic challenges, one of the biggest challenges for us has been our industry in Cornwall. Wages are particularly low. Whenever you go for a job, that's a good wage for Cornwall. That's what you hear. And a lot of our employed people in Cornwall work in the tourism industry. And obviously with COVID, we had the shutdown of lots of places. We did have some furlough, but also not a lot. And a lot of the places that were open this time last year are not open anymore. And what we're seeing at the moment is that a lot of places that have reopened are closing for several days a week, or only working on reduced hours, despite needing to be open to earn the money, because they can't actually find the staff. So now we've got a huge recruitment issue in Cornwall that doesn't just span the tourism industry, but it spans our organisation. Trying to find skilled workers is impossible. And also the hospitals. There's recently been a report from the NHS Trust in Cornwall that there's a real struggle in recruiting anyone because of the house prices in Cornwall. You will have seen on the news that I think now Cornwall's more expensive than London. People are working from home and wanting to live in a nicer place. And because of that, that has meant that most people have been priced out of being local people have been priced out of being able to live in Cornwall. So it impacts on everything. So and that's going to be a real concern, I think, going forwards. Thinking about getting skilled people, getting the right people to Cornwall, and balancing, you know, our ageing population and the challenges that we've got there. I think also we've seen a massive rise in food banks and the need for food banks and the use of food banks. And we've seen that they're not the typical person, if you like, that would be using food banks. There's a real need for food banks, for help, for support. A friend of mine works for a charity called Home Start, who work with young parents and vulnerable parents, and they've seen a massive uptake in their services, including people from kind of the middle class, the upper class, that are really struggling and needing that support and needing that help. So I think that what was there before, and we knew about before, has only got worse during COVID times. And I think, you know, particularly there's a fear within Cornwall at the moment. You know, we're on the precipice of the summer holidays. We know that everywhere in Cornwall is booked up for the summer holidays. And we know that restrictions are being lifted on July the 19th. So I think there is a sense of fear among many of the residents of Cornwall and many of my team across the work that we do, on the impact on the local residents of Cornwall and what that's going to look like, you know, with our one hospital. So that's kind of where we are currently. Thank you, Richard.
Thank you very much, Catherine. I think all of you have referred to the implications of the last year and a half for waiting lists, the fact that we've got a backlog across the country as a whole now of about 6 million. People have more severe conditions than they had before. My understanding is that particularly for surgical operations, some of them are taking longer because of that. And of course, we've got the workforce supply issues exacerbated, of course, by coming out of the European Union as well. Now, what I think we're going to do, because I'd like to bring all of our audience in, all of the other contributors. So, Billy, if you don't mind, we'll push you back about 10 minutes in the programme. We'll take some questions now, or points or comments. There'll be another opportunity before we conclude. But if that's okay with you, Billy, we'll ask you just to hold fire on your presentation for about 10 minutes or so. And now I'm going to turn to Kerry. And Kerry, have we got questions coming up in the chat room and through the Q&As? And if there's anybody who wants to ask a question by putting their hand up, and to do so personally rather than online through a written question, then you can do that as well. So, Kerry, any questions?
Not at the moment, Richard. So, yeah, people could start putting them in the chat box or raise their hand as you say. That would be great.
Okay.
Sue Easton. We've got one here from Sue Easton has raised her hand, Richard.
Okay, Sue, if you'd like to put your question direct, if it's to a particular one of our contributors, please say so. If it's a more general question, that's fine, and I'll try and point you in the right direction.
Yeah, no problem. I think initially it's to Catherineissen from Cornwall, but it may apply more broadly. I'm interested in access to services, and I'm interested in whether access to services get worse during the summer when you're flooded with visitors. So, for example, my understanding is that the main hospital in Cornwall is in Truro, I believe, and having looked at the area, I think that if you're in somewhere right on the very tip of the peninsula, you're about 22, 23 miles from Truro. And I'm just thinking, summer, busy roads, what's that like for someone who's, you know, in an accident or a road accident? Is that an issue that gets worse in the summer, please?
I think we'll ask you to answer that, Catherine, but I think all of our contributors will have the same problem. So we might ask for other contributions as well. Catherine.
Of course.
You're on mute, Catherine.
I noticed, I saw, sorry. Yes, no, it is an issue. We do have some local kind of cottage hospitals. There is one in Penzance that has got a minor injuries aspect to it, but we do have real issues in the summer. We also had issues during G7 because a couple of the wards were completely cleared so that there was a backup option if G7 needed any hospital treatment, which, as you can imagine, didn't go down particularly well during that time. But no, there is a big problem. I think, you know, with the traffic in Cornwall, you get to Truro and then it's kind of a single carriageway for most of the rest of the way. So it's incredibly difficult. Obviously, we do have the air ambulance if there are accidents and need to be dealt with in emergency. But also, like many other people, we've seen the queues of ambulances outside of Trelisk waiting to get in. Interestingly, what I've noticed around Cornwall most recently, those electronic boards as you drive into towns that welcome you in, it now says on holiday, got a health emergency, call 111. So it's everywhere you go is what you're seeing at the moment. So everyone's being encouraged to do that. But no, that is a massive worry. And I think, as someone said earlier on, it's the sort of injuries, it's the sort of things that get taken to hospital that perhaps wouldn't have been in the past. So I think that's also problematic and is a worry. And I think is one of the other things that's keeping people away from going out, particularly some of our elderly and the clinically extremely vulnerable, and what their concerns are. You know, it's safer to stay at home. So yes, it is a worry for us.
Yeah, Kieran, I wonder if you'd like to comment as well, because whilst there are other hospitals besides the main hospital in Lincolnshire, the Lincoln is the main point for secondary and indeed some tertiary care, and that can be as much as 50 miles away from some parts of the county.
Yeah, we have a significant issue around the summer months. As one of our other speakers said, is we don't really have a summer lull like other parts of the NHS, because we have so many visitors coming to our east coast, to Skegness, Mablethorpe, and all along there. We have the largest concentration of holiday caravans in Europe. And so people come for about 9 months of the year, and that places a significant burden on our hospitals and our general practices, because the funding stays with where they're registered. And so our hospitals are underfunded, our GP practices are underfunded. Just simple things like prescribing of drugs, the repeat medications, 9 months of the year, that's done by general practices in Lincolnshire, and it comes out of the Lincolnshire General Practice and Prescribing budget. But actually, the funding for those medications goes to their home GP practices and the home GP health systems. So yes, it creates a big problem. And the travel between the East Coast and the hospitals, both in Boston and Lincoln and at Grantham, creates a big problem. So as I was mentioning earlier, Grantham is our hospital that's doing all our non-COVID work at the moment, and that's a significant distance from the East Coast. Boston is 25 miles from Skegness, Grantham is 50. So yeah, the roads are busier, and it makes travelling much more difficult for those people who are potentially unwell.
And as Billy will no doubt tell us in a little while, even the funding for just the residential population who are domiciled there, there's been historic underfunding, which is why the Nuffield report showed that half a dozen or so rural trusts account for almost a quarter of the total NHS deficit because of that historic underfunding. Kerry, do we have any other questions coming in?
No, not at the moment, Richard.
Okay. What I think I'm going to do then, because I would like to allow time.
Sorry, Richard. I think James just wants to come in here as well, and we've got Sarah
James,
as well.
I can't see you on my screen, so my apologies for that. Do feel free to make your contribution, please.
I'll be very brief, but I was going to pick up on Sue's point there about travel distances between hospitals, particularly in those areas where we may see more visitors to some coastal areas. And what I would think is that if we reinforce a message that our chair at Confed mentioned a few weeks ago, which was we need to get into a position, particularly as we move into the ICS formation, is where we let local leaders lead. And that means coming up with more innovative solutions to some of these problems, so that we aren't seeing ambulances or cars sort of stacking either on the route to hospitals or on hospital forecourts, particularly for those conditions that don't require hospital care in an emergency sense. And I'll give you one just very brief example in Kent, where it has a rural and coastal community which is connected by a bridge. That bridge is often closed through high winds or car accidents, and that has an elderly population. And one innovation that they put in place in conjunction with the ambulance service and the acute trust was the implementation of what they called falls cars. And these were paramedics and occupational therapists who would go out to either at-risk patients or patients who had had a fall, with the aim of keeping them out of hospital, so that they weren't then travelling the 25-30 minutes into a hospital to then effectively spend a day or two there to then go back home under the care of the community. So I do think there is something about how systems can work together to be more innovative, rather than that traditional route that we had perhaps pre-pandemic of just simply ringing an ambulance and then taking elderly patients to hospital. We know that when patients have a fall, particularly when they're elderly and require surgery, that can lead for some groups to patients passing away or not going back to the place that they called home. So hospitals isn't always the right place for those patient groups in rural and coastal communities. So I would really reinforce the message of local leaders coming up with more innovative solutions rather than those traditional ones that have overburdened rural and coastal healthcare services.
James, if I may say so, I think you've really put your finger on the button here. I'm part of a group that's developing a leadership academy for Shropshire, which has its own rural issues to deal with. And the intention being that we provide local leadership for real, genuine transformation.
Yeah.
There's that lovely saying that says, if you always do what you've always done, you'll always get what you've always had. This is an opportunity with the ICSs to really, and if the centre is being both realistic and honest about devolved leadership, there is a real opportunity to make sure we go back to the system I started with when we had the old area health authorities. And I may sound like a bit of a Luddite, but it actually worked better than I think any other system we've had since. Now, what I'd like to do is to encourage all of the participants, please be thinking about questions that you'd like to put to the panel or your own observations or comments. They don't have to be just questions. I'm going to move to Billy Palmer in a moment because I know Billy will have some really erudite contributions to make. But we are going to allow time for all of the participants to make their comments, their observations, or to put questions to our speakers. So on that note, Billy, Billy is from the Nuffield Foundation. It's been my great privilege to work with Billy over several years now, and he's made a fantastic contribution to some of our thinking at the National Centre for Rural Health and Care as well. So with that introduction, you'll get no better, Billy. I'm handing over to you.
Well, thank you very much. Well, we'll see how erudite I can be. My son's school bubble has just burst, so I might get an interruption from him at some point because he's now back at home. But that sounds like a common theme for other people. It's quite difficult to follow up on all these very real practical examples we've got of some of the challenges. So I'm going to descend us from these real life examples to something a little bit more abstract, but I will help talk us through it. So hopefully there's a payoff from just a couple of slides I'm going to show. So hopefully you can see what is quite a blank slide at the moment. But so I'm Billy Palmer. I've been at the Nuffield Trust for a few years, and it's probably worth saying, well, why? We're an independent health think tank. There's a lot of topics that we could be interested in. So why rural remote services in particular? Because we don't have obvious skin in the game on this topic. Well, actually, as it turns out, after we've been doing a couple of years worth of work on rural areas, someone pointed out that actually we were founded as the Nuffield Provincial Hospital Trusts. So actually it was a charity set up to think about how to provide healthcare outside of urban areas. But in terms of actually the work we did, so even predating me joining the organisation, and don't worry about these are just small icons to show you what the reports look like. I'm not expecting you to read what the titles are. So colleagues of mine were looking at how can we better deliver sort of medical training almost to make a more sort of generalized workforce. And actually this morphed into some work on how do you think about acute medical care in small hospitals. And there's a line, sort of an opening line in that report saying, too often the knee-jerk reaction has been to try to close and downgrade essentially small services rather than develop solutions that better suit the needs of the local community. So really relevant to what we're talking about. And I think just on this, this idea that as soon as something looks a bit expensive or a bit difficult to do, well, let's try to consolidate it into a larger or more urban hospital. You never hear people saying about let's move hospitals outside of London because the additional cost they have in employing staff. So I think it's quite interesting in terms of how the debate is different. It's framed differently when it comes to rural areas. And then in terms of where I started working on this topic and kindly supported by the National Centre for Rural Health and Care, who provided some funding, but more importantly gave us a sort of steer in terms of what to look at, where the risk could be, which were entirely borne out when we looked at the data. We did a first piece looking at the sort of funding and some of the quality outcomes, we followed that up a couple of years later, looking at the where things stand currently. So trying to develop a bit of a dashboard of performance and how particularly COVID might have affected things. And then I'm just going to quickly flag as well the rural proofing toolkit, which Rural England CIC, again supported by the National Centre, produced, and that's to help commissioners and providers be thinking through what are the implications, what are the key considerations for creating strategies, for developing solutions around rural healthcare services. But let's go into a bit more detail about some of this. So as I said, super abstract. Now don't worry about this, but I thought let's introduce an equation into this. The pandemic has done lots of bad things. One good thing is people have got used to some interesting maths. We all learned about exponential growth, and we also have now all learnt about Greek letters with the variance. So I even put a little delta there. But all as this is saying is that we need to, it's really important to think about what are the implications for your income of being rural and remote, what are the implications for your expenditure, and if you combine those two together, you get a rough idea of what the sort of financial position of a service might be, plus or minus some degree of quality or outcomes. It might affect that if you're underfunded. This is a simplification because in reality, you've got things like efficiency, which can be some of the sort of the settling figure in here. But so don't worry too much about the detail of that equation. Let's talk through some of the specifics. So in terms of income, the allocations, and Richard alluded to this already. So the first thing to say about how the overall national pie, the overall budget is separated out to local areas. A large element of that is because policymakers trying not to destabilise health economies, so they therefore slowly move from the current levels of funding to what they think is a fair share. And this really penalises local areas because historically a lot of healthcare provision was provided in urban areas. So in particular, London has a large number of very big hospitals, so there's always a big spend in that. So then when they try to calculate what's a fair share, actually it should be outside of these urban centres, but it's slowly making its way. So and that has the effect of penalising for core hospital services, for primary care, and also for specialised hospital services as well. Just taking that latter one, specialised services, the historical element in that has the effect of moving about £700 million to predominantly urban areas. So it really is, it's a material difference that a quirk in the allocations has on the level of funding that goes to local areas. So that's in terms of the sort of the standard technocratic allocations, as it were. But then you've got this discretionary funding. So you might have, for those specifically involved in healthcare, you would have heard of things like Sustainability and Transformation Fund, but there's been various other specific bits of discretionary funding. They typically go towards urban areas who, bigger hospitals might be better suited to sort of write business cases to get hold of that funding. There might just be sort of a precedent to go towards those services. So just taking that Sustainability and Transformation Fund, 30 million out of 1.8 billion went towards the 7 most remote trusts in 2017-18. So it's far smaller than you would expect if it was divvied up on the basis of just the size of them. So that's the income side. So they seem to be penalised there. And then what about the expenditure side of it? So in terms of the cost of providing care. So let's start with hospitals. Well, NHS Improvement's own report suggests that fixed costs for emergency services account for about 80% of costs. So there is a real, irrespective of your size, you have this set fixed cost just for providing emergency services. So therefore, the bigger you are, presumably the more efficiently you can provide the services per patient. So there is a penalty there in being smaller. Some data that came out only last week in an OECD. So that's the organisation that sort of looks at high-income countries, but they focus this particular piece of analysis just using English NHS data, and they found that a 10% increase in the catchment area of your population seemed to be associated with a 6% decrease in costs per patient for cardiology. It was about half that level for maternity and obstetric services. So still a substantial almost economies of scale issue going on. And then moving away from hospitals into primary care, the management consultancy Deloitte, their calculations with that a 10% increase in list size is associated with a 3% reduction in cost per patient. So again, bigger is cheaper. So there is this cost penalty for rural and remote services where they particularly where they're smaller. There's a number of reasons why that some of these cost pressures happen. It's about workforce, recruitment and retention difficulties. There's more professional isolations, sometimes higher overall staff costs because you have a slightly more autonomy, potentially if you're working in a smaller service. There's distance, higher travel costs. There's some issues about access to some resources, whether it's telecommunications, training, consultancies. There's many reasons, and they're very well established in the literature, not only from England and the UK, but also internationally about why there might be these higher costs. But as I mentioned earlier, that's not to say because they're more expensive we shouldn't be providing services in rural and remote. As I mentioned, we're not going to stop providing services in London because we pay higher staff salaries because of the London waiting. And how material is this? Well, it's very material. So Morecambe Bay, where they have given a special uplift to, they get about 20 to 25 million pounds extra a year because of their additional costs. And so what does this result in? Well, Richard alluded to it. It tends to be sort of a dodgy financial position for some of these services. So the 7 particularly remote trusts, it's a category defined by NHS England Improvement, so they're unavoidably small due to their remoteness. They account for a very small proportion of all trusts, but accounted in I think it was 17-18 for a quarter of the overall deficit. There has been some adjustments to deficits now, trying to write off some of the debt, but that's not going to affect the underlying financial problems that these services are facing through, as I say, no fault of their own. And the other sort of outcome you might see from these funding issues is, well, what about quality? What about outcomes to patients? Well, when we looked before, you had a high number of sort of rural providers that typically have a poor performance on CQC measures, so being rated inadequate. For every 20 A&E attendances, you had an extra 1 waiting more than 4 hours, so they do worse against that A&E target. In remote services, that's 4, and similarly in those services, 1 in 10 extra long waits for elective care, and they have more delayed days per admission. So there are indications of some issues in terms of the quality of care they can therefore provide. So I guess the next question is, well, that was our sort of previous analysis to bring this up to date into the age of COVID. Well, you've got direct issues, COVID cases, COVID mortality. You've got some indirect issues, some of the economic measures, and actually it's quite interesting. And this was mentioned earlier by one of the speakers that actually a higher proportion of employees furloughed in rural areas than urban areas. Saying that was the case as of summer last year. And some maybe some other unexpected issues. I certainly wasn't expecting to see less unoccupied floor space in rural services compared to urban, so that gives you less flexibility to manage your estate when you do get a sort of a seismic issue as COVID was. And also even things like the Nightingale policy, that was very much an urban centric way of dealing with additional demand. And even then, one of the other policies was around use of the independent sector to try to make headway into some of the backlog of care well, we need to think about where that independent sector is distributed across the country. So there's some issues which compound upon the underlying pressures that urban areas face. Again, don't worry about the detail of this. This little dashboard I've shown here. I think you were in the meeting invite. There's a link to the actual report itself, so you can look at the specifics if you're trying, for example, to draw up a business case about why we should take rural services more seriously, and why we should be looking at the funding of them. But just to say that, again, supported by the National Centre, we looked at how rural and remote services were doing over time and against their more urban peers, and highlighted some of the particular issues they faced during COVID. And I won't repeat them because, as others already mentioned, about waiting times, etc., and particularly drop-offs in certain areas. The ones I meant, IAP services, so that's sort of talking therapies, you might describe them as, and also continuing healthcare, so that's for people with particular social care needs. There's a real drop-off in numbers of people being referred for those services, which I don't believe to be because the need went away, but that's just because there's now an unmet demand, and indeed we've yet to see some of the direct and unintended impact of COVID yet. The one thing I will say about monitoring is we need to think about how do we categorize these services. You know, you never speak to a healthcare service which doesn't say it's unique, but there are some broad categories. But the way we often think about rural is probably in too broad a sense. You know, is it rural? Is it remote? Is it small? Is it coastal? Is it almost a junior partner in the wider health economy? And all of those will have slightly different effects. And I think when we do monitor how these services are doing, we need to be conscious of that. And also in terms of next steps, and I alluded to this already, the rural proofing toolkit. So you know that draws out how you can consider rural considerations for main hospital services, for primary care, mental health, public health, social care, and workforce. So for anyone thinking about commissioning, monitoring, providing services, that's of course a useful tool, and that came out only very recently. And again, I think you've got a link to that in your meeting invite. So I think that's enough from me, but hopefully that gives you some insights in a slightly more abstract way.
Thank you, Billy. I owe you an apology to start with. I introduced you as being from the Nuffield Foundation, which I do know is a very different organisation to the Nuffield Trust, and my apologies for that. So it's the Nuffield Trust that Billy is from. Just a quick comment about the Morecambe Bay 25 million a year, and just to say that was a largely arbitrary allocation of 25 million. It wasn't based on any rational analysis of what was needed, and the amount was designed to manage the politics rather than being based upon how to manage the reality of providing care in a coastal community. What we're going to do now, I'm playing a little bit fast and loose with the program, just so that we can allow everybody to make a contribution. I'm going to be going back to our speakers just for a very short statement about how they've introduced some new innovative mechanism for managing the various demands and challenges we've talked about. But I would like all of the participants to also be thinking about how we provide an ongoing community of interest, an ongoing forum to allow people to share ideas, to share the challenges, look to each other for support, etc. So be thinking about that if you wouldn't mind, because I will allow a bit of time at the end for you to make those contributions. So I think in the interest of time, what we ought to do now is just to go back to the speakers and ask you just to make a very short contribution, a very short reflection on the way your area has made some change in the way services are designed and delivered to reflect the very challenges that we've talked about this morning. And I'm going to run in the same order if I may. So I'm going to start with you, Kieran. If we could keep it brief, because I would like to allow time for the participants to make their contribution as well. So Kieran, your reflections, please.
Kieran, just before you start as well, just from myself here and the chat, apologies to Sarah, I missed your question earlier, but there was a question from Sarah, Richard, about addressing health inequalities and how we design services, and also another question about integrated care systems. So just if panel members could reflect on that as well when we come to the conversation. I know James is going to pick up some specific conversations with participants, so apologies to Sarah there.
Okay, that's great, Kerry. Thank you very much. Over to you, Kieran.
So Ivan, sorry, Richard, I believe that the question is what changes have we made locally?
It is.
Yeah. So I think the main thing we've done is, as I say, move to more remote consultation, both within the hospital and the primary care sector. We've also had to use a different form of workforce. So through primary care networks, we've been enabled to use first contact physiotherapists, clinical pharmacists, nurse practitioners, all sorts of different people other than general practitioners. And that has actually been made things much better for our patients in terms of getting to see the right person, rather than sometimes I don't have the skills that are needed. So a physiotherapist is much better at seeing someone with musculoskeletal conditions. The difficulty that raises is that when I see someone, they tell me 3 or 4 things they want to have dealt with. And I try and deal with all 3 or 4 because I have a general knowledge skill of all of those things. Whereas when they see a first contact physio, they are only able to do musculoskeletal problems. Clinical pharmacists can only deal with medication issues, etc. So whereas it has helped in terms of we can recruit those sort of people to some extent. So it has the recruitment issue is less, but it doesn't necessarily fulfill all of the patient's needs. And even though we can recruit them, it is much easier to recruit those people into those areas where it's always been more easy to recruit GPs as well. So the further east you go in Lincolnshire and away from the big towns and cities, it becomes more difficult to recruit even clinical pharmacists, physiotherapists, etc. So in some respects, it's a good thing, but in other respects, it's not so good.
Kieran, as you've got a wider range of community and primary care professionals involved, to what extent is it a real impediment that they can't all share the patient records because of the various legal restrictions for doing so?
Well, actually, we find that a lot of the time they can share the medical record, because if we ask 99% of patients, are you happy for us to share the record? They say, well, we thought you already did, and so we just do. There's a small number of patients who don't want the medical records sharing, and so we don't. But actually, that's one thing that IT has really helped in that respect. We have in Lincolnshire something called the Care Portal, which sucks the information from 7 or 8 different health systems all into one place, and that really does make the accessibility of information about patients much easier, as long as they consent, but most people do.
Wonderful, thank you, Kieran. Maybe we can move on to you, James. I know until relatively recently you had your role with the Medway Trust, so you might like to just reflect on how you design services to recognise the particular challenges of rural and coastal communities when you were there, as well as what you've seen in your wider role with the Confederation.
Yeah. So I think that there's four key areas. And I'll be very brief about each. But the first one Kieran's touched on, which is expediting more digital solutions. Now, a piece that can be more difficult in rural and coastal communities for some of the reasons that colleagues have spoken about internet bandwidth and the like. But there is most certainly, we saw the impact of this during COVID, both in Medway, in Kent, but in other parts of the country, where we saw virtual clinics taking place for things like triage for orthopedic, right through to primary care. And it worked very well. And the risk is that we simply go back to what we had before, and that would not be the right thing. I think the second thing is to continue, and Nicola touched on this, which is breaking down the organisational boundaries that have existed. The ICS formation will take place from April next year formally, And I think there is something about not going back to just trying to deal with our component parts of the health and care system. This has to be done as one system. But in the other two areas, I'll be more specific. So the first is, if we're going to genuinely look to address health inequalities and the backlog, what we've seen in one part of the country where they have 2 or 3 hospitals covering their catchment area is that they've dedicated one hospital entirely to diagnostic and elective. Now that might sound very sensible and very easy. It's certainly sensible, but not easy, because of course there is a demand on beds, particularly when we have emergency presentations. But what this hospital has done is ring fence those beds for elective and diagnostic, meaning that flow of patients going through the elective process will continue regardless of the pressures on the other hospitals. And that is a surefire way to continue your elective trajectories and making sure you make headroad into the backlog. And then linked to that, which again Kieran touched on, is around the workforce gaps and the systems that we've seen work more efficiently, both in terms of personal experience, but more latterly when speaking to chief executives up and down the country, is that the ones that are working better than others are where there's more innovation when it comes to workforce. If we continue to all go out and recruit more nurses and physios and the like, there are not enough of them. So all we end up doing is moving the problem around the country in terms of vacancy rates. So we've got to come up with something new in terms of new roles that are both appealing to a younger generation, but also appealing in terms of dealing with the issue. And we've seen this work again. First practitioners that Kieran mentioned are very effective in triaging patients, particularly those with MSK issues. And we've also seen, I mentioned the Falls car earlier, which is that innovation between an ambulance service and occupational therapists. So expanding those sorts of innovative solutions will be far better than relying on what we know perhaps is a bit more fragile today than it even was pre-pandemic. And going out and simply recruiting more nurses, either locally or internationally, isn't going to solve the problem in the short term. We've got to be more creative with workforce solutions and sort of humans and machines working alongside each other more effectively.
I think we might have lost Richard for a minute whilst I think his screen is frozen, but I'll come to Billy then whilst we're waiting for Richard to come back online.
Yeah, I just wanted to add on to that really important point that James was making about workforce. And there's a few things we need to think about with workforce. It's about who holds control and what influence do we have over it. So, in medical training, there is still some levers, in terms of the positioning of the medical schools, and there's been some positive moves there, and also in terms of where placements can be for subsequent junior doctor training. In terms of, hi Richard, you're back with us.
We lost you for a minute, but I've brought William into the conversation whilst you were frozen.
So, and so just in terms of the rest of the clinical workforce, whether it's nurses or allied health professionals, there's far less control in the system. It's been left to the education market to determine, and there are some levers involved in that. There is some funding that goes to universities to reflect the fact that it's an expensive course to run some of these, and so you could be tweaking that and being a bit more deterministic. But it's really important, because if we just leave it to the market, it might be efficient in some respects, but I think it's not going to have the equality and the fair distribution that we're looking for. So we need to think quite strategically and across more than just the health sector, but also education sector as well, to make sure that happens.
Thanks, that's really helpful. Richard, we can see and hear you now. If you want to take over chairing, or I can carry on. Can you hear us, Richard? No? Okay. Listen, can you hear?
I'll just very quickly just add on to what Billy mentioned. I completely agree that investing in universities and the like to create a better longer term pipeline for workforce is absolutely the right thing to do. provided we align it with the genuine issues that the NHS is facing today. So, for example, we know where the backlog exists in terms of volume, but we also know where the backlog exists in smaller volumes, but equally smaller expertise. So our members tell us that the biggest areas of backlog are in orthopedics.
I'm sorry to interrupt. Can you hear me, Kerry?
Yes, we can hear you. James is just finishing off
Kerry?
a point, Richard, and then I'll come back to you. Okay, James, go on.
Orthopedics, ophthalmology, and ENT and dermatology. And 3 of those 4 are areas where we know we've always struggled in sourcing expertise in medical schools and in nursing and other professionals. So that backlog, and we know, again, Secretary of State was very honest in saying that the backlog will grow before it reduces. And if we don't do something differently today, those health inequalities will get worse.
Absolutely. Thank you, James. That's really helpful. I'm conscious Richard has been struggling to join us. Are you there?
Kerry, can you hear me?
Yes, we can hear you now, Richard.
No, I haven't.
Richard, I think you're struggling. Can I suggest you maybe switch? Can you switch your camera and mic off, Richard, and I'll carry on just so we can finish off on time? Okay, we still haven't heard from Nicola and Catherine. So Catherine, if I can offer your reflections, if I could come to you for some reflections, that would be great.
Yeah, of course.
Thank
I
you.
think in terms of the services and things that have changed for us, we've had to absolutely look at how we deliver. A lot of our work was face-to-face, which obviously had to change. So we've had to go online, but also we've had to provide other options, because for lots of people, they don't want to go online and they don't have the access to that. So we have been working with the people we serve to make sure that we work with them the best way they want to. So it might be telephone, it might be going for a socially distanced walk, it might be using IT systems. And I think what's been really interesting is we've seen a real divide between the younger people we work with and the older people we work with, because we deliver lots of youth services as well. And we all assumed that young people would be the ones that wanted to work online and we would work with them, but they absolutely don't want that. They actually want the human contact. They want to meet up with people. So we've spent time working with everyone to find out what's the best way of delivery, and then tried to change our services to meet that. And as part of the wider ICS discussions that are happening in Cornwall at the moment, we're really pushing the voluntary sector. I don't know about elsewhere, but I think sometimes we're seen as a bit of a poor relation, that we do it voluntarily because we're the voluntary sector, but we're not. We're highly trained professionals that have an awful lot to offer. And it's definitely been recognised within the mental health sphere, where a lot of the services for mental health in Cornwall are delivered by the voluntary sector. So I would just, say that it's really good to further that partnership and build on the skills that are available. And so therefore you've got more accessibility for people within the voluntary sector and within the NHS. And I expect Nicola will probably echo what I've just said. Thank you.
Thanks, Catherine. To Nicola then, please.
Yeah, absolutely. Echo what Catherine says. I guess that I suggested 3 areas earlier where we'd worked on, which was firstly technology enabled care, which I think we've covered a lot today. Secondly was the partnerships, which I think others have covered really well, and you have to mainstream those. So the non-bureaucratic approaches we took to managing our partnerships through the COVID period is something that now we've maintained. And then finally, the one for me linking to the workforce conversations we've been having is around, when you are small and beautifully formed, how do you bring your services together in clusters which enable you to have much more resilience and cluster your services around patient pathways and not around individual service lines. And I think that's really important to give you that resilience. For example, through the COVID period, when our patients weren't wanting to access podiatry services because they were at home shielding, we lifted our podiatrists, and our podiatrists worked in a really joined up and integrated way as part of our community nursing teams. So it was about being really innovative around how you use your workforce that you've got to meet the demands and pressures that you're facing. And that's been in some national articles now around the value that added. So yeah, I think the innovation bit that somebody suggested earlier on is really critical. Think about what your staff can offer outside the norm and link them together.
Thank you, Nicola. That's really helpful.
Can you hear me now, Kerry?
Yes, we're all back. We've just finished our reflection, so I think we're in summary remarks now, Richard, if you want to take over.
Okay, my apologies. I was completely disconnected abruptly and couldn't reconnect either. So my apologies to everyone. So and I couldn't until just a couple of minutes ago even see or hear what was going on at your end. So everyone's completed their reflections, have they?
We have, yes. Yeah.
Right, that's wonderful. Thank you. Well, I'm very pleased to be back with you, although apologies for so abruptly disappearing. I was going to ask one or two questions as well, but it may well be that they've been asked and they've actually been answered. I was going to ask the participants, as I said earlier on, to give us some indication as to how they would like us to proceed from here in building this community of interest. Have you been able to synthesize any comments coming through on the chat facility, Kerry?
No, we haven't had a chance to, Richard. My brilliant colleague Gemma has posted a link in the chat function here for colleagues to reflect on today's session and to offer us some feedback and also to indicate if they would like more of these. My sense is we scheduled an hour and a half for this conversation and we've still got lots of questions and comments from people that we haven't been able to cover. So I think this is a strong indication potentially that colleagues would like to continue on with future conversations.
Well, can I make a suggestion to you, Kerry, and to everybody else that we take those questions as the basis for another session? So the starting point are the issues, the questions, the comments that people have already made, and you and I, Kerry, can perhaps go through those, including with the speakers as well. There are a number of questions not now to be answered, but I was keen to ask all of our participants if they could send one message to those leading the integrated care systems about how to manage the process of integration. If they could just say, do this one thing, what would it be? Because I think that would throw up some really interesting pointers for the ICSs. I was going to ask Catherine as well about the cost to individuals. We talked about the costs of managing the services, but of course individuals in remote and coastal areas also have additional costs that they have to bear as well. Billy mentioned the rural proofing toolkit. This has only just been published, but it's really worth looking at. It's a means of providing a lens on policies which usually have their origins in urban circumstances and situations, and about how to ensure that we put them through a rural lens to make sure that they are at the very least rurally sensitive. And my argument would be that we ought to start from the bottom up actually and be designing systems and services that have their origins in rural areas. And then the final thing is, how on earth do we create, given all the demands on the system, not least as a result of COVID, how on earth do we create the capacity for change, the time to actually invest in new ways of doing things when we're just trying to manage with the existing system what we have now? So those would be some of my reflections about the questions that we need to be looking at and answering for the future. And Kerry, can I just ask you, we've got a list of the contact points, I think, for all the participants. Will we be able to easily communicate with them after today?
Yes, absolutely. Yes, if you've shared your email to register for this event, we will be in touch in the next couple of days. We'll reshare the Survey Monkey, and obviously we will look to bring you all together soon.
And can we ensure that everybody has a link into the rural proofing toolkit as well?
Yes, it's available in the invite that came out to participants today. So you should be able to link into that.
Okay, well, as we've now reached 10:30, I'd like to conclude just by thanking all of our speakers who have provided such a stimulating introduction to some of the themes. It's no more than an introduction because of the times, but nonetheless extremely helpful in stimulating some of the discussion and sharing thoughts. My thanks to the participants for bearing with us, including my absence, although some may regard that as actually having been a benefit. So thank you for picking up and managing that, Kerry. And I want to particularly thank the NHS Confederation and Gemma Critchley and Kerry McCabe in particular for organising this in such a way as we were able to involve so many people. On that note, let me bid you farewell, say thank you to all of you. Are there any final messages or comments that we need to make, Kerry?
No, just thank you as well to yourself, Richard, for some brilliant sharing. Thank you. We look forward to working with you more.
I look forward to maybe an even more interactive one next time. So thank you very much. Go safely, and don't forget that COVID is still out there. Take care. Bye-bye now.